Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. We're going to talk this session about a very common but not talked about enough problem called urinary incontinence. Now, this is not something that should be hidden in the dark or never spoken of except in whispers. In fact, urinary incontinence is an extraordinarily common problem in women, most common in women after menopause or starting during the perimenopausal years, although it can occur at earlier ages. So, what is urinary incontinence and what are the different types? Well, the most common is what's called stress urinary incontinence. Now, this is the type where you lose urine, but you don't know that you're going to. You have no sensation. It's just that you have urine coming out, often in relatively small amounts, but sometimes it could be quite a lot. And it could necessitate constant wearing of protection, wearing like adult type panties that are like designed for like they're like adult type diapers, or just using pads that people use for menstrual as a menstrual product are often worn. And so it really is very disruptive. Of course, the urine can get on the clothing, leave a urine smell. So it is not a little problem. It is highly disruptive to the quality of life of a woman. Now, what kind of initiates such a problem? Well, it originates typically from childbirth. Although it can happen, it's quite uncommon for a woman who's never had a pregnancy with a baby that got big, like to around full term, to have stress urinary incontinence. And most common with women who have had a vaginal delivery. So when a woman has a vaginal delivery, this whole baby is coming out vaginally, and it can cause some disruption of the connective tissue that underlies the urethra, that's the tube that exits the urine from the bladder, and the surrounding vaginal tissues, the fascia. The fascia is like the connective tissue that holds everything together. When you don't have health of fascia, you can end up having things like hernias. And in the vagina, it can manifest as a herniation of the bladder called a cystocele, where the bladder is pooching into the vagina, or the other side, the rectum pooching in, and that's a rectocele. And then you can have injury to the tissue around the urethra that I mentioned, the tube that takes the urine from the bladder outside the body, and the tissue supporting the urethra can become injured and start to lack the adequate support so that the urine kind of funnels out and comes out. Now, this is a real problem that many women face. Now, what triggers the actual loss of urine? Anything that increases intra-abdominal pressure. So it can be things like laughing, jumping, even walking, coughing, sneezing, all these kinds of things that people do every single day, and suddenly urine is just coming out. And think of it as when you have like a funnel and the urine is in the bladder and it's tipping down instead of a little bit up, and it just goes down. Now, it's more complicated than that because it also involves some neurological issues as well. So it's a combination of injury involving the neurological system, the connective tissue, and you end up with stress urinary incontinence. Now, this is the majority, but not at all the only type of incontinence that women face. Now, in terms of when they did surveys, they found that incontinence of every type that we'll touch on occurs in women in their 50s. We're talking about in the neighborhood of over 40%. And in women who are in their 60s and above, it's even more common, like 50 something percent or higher. So this is really common. So if you have it, you've got lots of company. But when they look at surveys, they find that only a small percentage of these women ever talk to their physician about the problem. And even worse, many times the physicians don't ask them. So nobody is involved in a conversation about this really important problem. Now, of different kinds of incontinence, and we're going to go into more, about 70% is actually the stress urinary incontinence type. We'll come back to therapies. Now, what is the next most common type? It's urge incontinence. Now, urge incontinence is where a woman has a sensation, I have to go to the bathroom, but it becomes overwhelming, like, oh my gosh, when I have to go now. Okay. Like you don't have time to say, I'll hold it, I'll go at the next commercial break or something like that. No, when you got to go, you got to go. You make a beeline to that bathroom, and sometimes you make it and sometimes you don't. You just cannot keep it in, and it just comes out. And that type of incontinence can have a complete emptying of the bladder. So it could be like a flood of urine coming out everywhere. And it's so, so upsetting. So that is where the bladder just doesn't have the stretchability that it did. So it triggers the sensors that say, time to empty the bladder, but it doesn't give you time to hold it and control it. The bladder goes into like a spasm and out comes the urine, like the whole bladder empties. When you have stress incontinence, it's not typically the whole bladder emptying. It's a little bit that comes out, but sometimes it could be a lot, but it's certainly enough to totally wet all your clothes and make a mess and make life miserable. So they're both bad. And guess what? You can have both. It's not uncommon to have what we call mixed urinary incontinence, where you have both the stress and the urge incontinence. Now, there are other types of incontinence that are somewhat unrelated to the female aging process. And they would be things like if you had a spinal cord injury, so you don't have proper neurological control, if you have other neurological diseases like multiple sclerosis, where you don't have proper bladder neurological sensations and control, where you can also have bladder atony, where the bladder doesn't get the sensation of when you need to go, and it doesn't contract properly, and it just overflows, and then you get what's called overflow incontinence. But we're not going to go into those other types of incontinence. We're going to stick with stress urinary incontinence, urge incontinence, and mixed incontinence. So these are commonly faced by women, and most commonly, as I mentioned, in the perimenopause and especially in the menopause, and it tends to get worse with aging. It's not like aging makes it better. No, it tends to get worse. So why is it? Why is it that around the menopause? Well, I bet you could guess the answer. It's loss of estradiol. Estradiol is a hormone that manages the health of every structure in the body, including the connective tissue. It also manages the neurological system, especially the autonomic nervous system, which is the controller of bladder sensations and bladder function. So when you don't have adequate control of your neurological system, that's a big problem. Of course, that's what underlies urge incontinence. And when you have connective tissue problems, that's what underlies stress urinary incontinence, because the tissues that connect everything together and hold all these structures up becomes like frayed and more fragile. Estradiol maintains the production of collagen, which is in all the connective tissues. And so you end up having dysfunction of the production of collagen. You don't have healthy connective tissue structures that support everything. And that's why things in the vagina tend to go south, literally and figuratively. They start drooping, and it's often very common for women to have a cystocele, a rectocele, urinary incontinence of the stress kind, and also uterine prolapse, where the uterus is falling down as well. Sometimes it's having the bladder be droopy that actually prevents stress incontinence, because the droopiness causes the urethra to actually then go down and then be sort of pulled up. It changes the anatomy, the sort of directionality of the urethra. And then if a surgeon fixes the cystocele, the droopy bladder, and pull it back up and put in like some support with like your own natural fascial tissue and put in the stitches to hold it up, then the urethra becomes back where it should be, but not really because of the changes. And so then suddenly stress urinary incontinence is manifested where it wasn't before. That's why usually when a doctor is going to do a repair of a cystocele, they will also do a surgery where they put in like a little sling. It's like a little ribbon of mesh tissue. It's a synthetic mesh. And they put it in to support the urethra so that it's not like coming down. So you have that little pull up. So the urine has to go up before it goes down. And that helps to prevent stress incontinence. And that's usually either this type of a sling. We call them sling. And there's a couple of different types. We won't go into that now. But they call them urethral sling procedures. So that actually is one of the treatments for stress incontinence, whether you have a cystocele or not. Like I said, a lot of these processes in the vagina go together, but not always. So you can treat with a sling where you put this little mesh ribbon under the urethra very gently. It's not with any real tightness, and it just gently supports the urethra. It's a very, very quick surgery. I've done many of them in my career, and I've had great success. Many doctors do them all the time. Urologists do them, urogynecologists do them, and gynecologists who are trained in them, even though they're not urogynecologists, can do them as well. And so they can be quite successful. So that is one type. But what if you don't want to have surgery and you have stress urinary incontinence? What else can you do? Quite a lot. So in my office, I fit patients for pessaries. So a pessary is like a holding device, like a scaffold. It holds it up. And they have special ones. They're different sizes and shapes, and everyone is different. So you got to find the one that's right for you, and you have to be specially fitted by a doctor like myself, a gynecologist. And the kind that I've always used, they're shaped like a ring. And at one end, there's like a little prominence, okay? So if you look at it, it kind of looks like a ring with like a diamond on top. Of course, this is all silastic material, but it has that shape, like a ring with like a knobby thing at the top. That knobby thing fits right under the urethra, and it pushes it up. So when the urine exits the bladder, it can't have a straight downward course. It kind of has to go up and then down, and that will help to prevent incontinence of this type. And many patients find it very, very useful, and they like it. You would always combine it with another type of treatment, which is necessary for proper use of the pessary, but also can help even on its own. And that's vaginal estrogen treatment or vaginal DHEA cream or suppository treatment, because they help with the tissue quality and the health of the vagina itself. And that has been shown to help with incontinence. And not only just stress, but also it can help with urge incontinence as well. So that is very helpful. And some will use, and I do this too, the compounded estrogen product called estradiol. This is where estradiol can shine because it really can help with the incontinence problems of women and also vaginal atrophy. Now we call that genital urinary syndrome of the menopause because it also helps with the bladder as an additional benefit. So using a pessary, using vaginal hormones, which by the way are totally safe even in women who are undergoing breast cancer treatment. So talk with your doctor if you are in that situation, because the dosings are so low that they don't become systemic. Not that it's shown that it's even dangerous anyway, we won't go there, but most every oncologist will approve of vaginal hormone treatment for women who are undergoing breast cancer treatment or they've had a history of breast cancer. So women do not have to suffer from this problem under those circumstances. Now, what else? There are what are called bulking agents. So bulking agents are like filler. Like, when women have filler in their face, they want to have bigger cheekbones, or they want to get rid of the wrinkles over here, like next to their nose and mouth, and they put in filler. Similar stuff is put around the urethra to bulk it up, to create more support, and to keep the urethra from just drooping down. So bulking agents are used with mixed success, usually not for the most severe cases. The more severe cases usually do best with the surgical procedure I mentioned. And then what about other modalities? You can use radio frequency. Radio frequency is where you do little trauma to the tissue with the idea that tissue will then regenerate and make new tissue and also tighten. So think of it as a tightening device. So it can sort of tighten the tissue so they're not so droopy around the urethra. So some women, particularly the milder cases, can potentially benefit from treatments with radio frequency. Some people have tried vaginal lasers, mixed results, but those are other modalities that can be utilized. Also, the other thing that I always start with is pelvic floor physical therapy. It's like creating exercises for the pelvic floor muscles, and that actually creates more ability, like strength in the tissues, and holds things up better. And for many women, especially the milder cases, this can be a game changer, can really help. And that's where you've heard of Kegels, those famous Kegel exercises. It involves Kegels, but not just Kegels. There's a whole bunch of different things that pelvic floor physical therapists will work with you if you have incontinence of any type. So it's not just stress incontinence that they work with. They also work with urge incontinence, and it can be very, very helpful. And so many women have a combination, mixed incontinence. So it's very beneficial. I love my pelvic floor physical therapist. And once you learn, you'll be able to do some of these exercises on your own. Now, in addition, there are devices that can be used intravaginally, both for stress and urge incontinence, that create a little electrical signal that create contractions. And these little electrical stim devices are really useful. In Europe, this is like their main treatment, and you have to use them for life. They're not curative. They're therapeutic, and they're really beneficial. So these devices have come a long way, and they're all like cord-free now. They're very easy to learn how to use, and there are many on the market you can buy over the counter, but I really prefer working with a pelvic floor physical therapist to get everyone properly educated on how to use it and get the right one for you. So those are really helpful. Now, what about urge incontinence? I covered a little bit because there's some overlap with these, as I mentioned, and many women have both. So urge incontinence, though, is a different etiology. It's when the bladder goes into a spasm, and it's from a neurological change because the estradiol is really critically important for regulating neurological systems and the autonomic nervous system. And the sensors, they're all like sensors to pressure in the bladder, become dysregulated, and the bladder goes into that spasm at small capacities. So what do women do? Well, they often can have bladder diaries, voiding diaries, so they kind of watch to see how long they can go before they get these signals that they have to go. And of course, keeping the bladder more empty, but that becomes the real training for the person. But sometimes that is necessary to not, that doesn't mean that you restrict drinking fluid, but you may at certain times, like if you know there's no bathroom available for a while, you may not want to fully hydrate, but you don't want to dehydrate yourself. You want to do timed hydration, and you want to do regular bladder emptying so that you don't have a really full bladder. So if there is an accident, you don't lose like a ton of urine. There are pharmaceutical agents for this problem, and it overlaps with overactive bladder. In fact, sometimes it's a continuum because an overactive bladder is someone who has to go to the bathroom more often, and sometimes will also develop into the urge incontinence. And so these drugs, I'm not going to really go into, but I want you to know that there are drugs. They are cholinergic inhibitors, so they work to block the neurotransmitter acetylcholine, sometimes they're called muscarinics, and they work to help reduce bladder spasms. There are some side effects like constipation because it's working to sort of block contractions. And of course, in the intestines, you want to have contractions so you don't get constipated. So constipation is an unfortunate common side effect of these medications. And the other is that there's some question that because in the brain, acetylcholine is important for memory formation, that it could be a problem, especially in the most elderly women, on cognitive function. But for some people, these drugs are very useful, so I don't want to pan them. People just need to know. And sometimes trying them can be a good thing for the overactive bladder, which goes into the urge incontinence. So those are really important things. So you can do the bladder stimulation. There are also other things that can be done, which are much more advanced. I do not do these, and they're implantables in the spine that affect the spasming of the bladder. For some people, they can be a game changer. These, what they call like interstim, these implantables in the spine. And there's a newer way that you can do perineal nerve stimulation. So it's like in the lower leg, they put like a little stimulation, and it actually works on the bladder. Like, isn't that amazing that these neurological connections, sometimes acupuncture can actually be helpful as well. So these are some really very useful things. So there's been a lot more research into these incontinence problems. So it's really important to be aware that there is no reason to suffer in silence and think that this is an absolute unavoidable issue for women with aging. It may happen for so many different reasons, but that doesn't mean there aren't very positive steps. In fact, urological issues in women has become a subspecialty in my field of gynecology, urogynecology, and it overlaps a lot with what urologists do. But they stick to female problems and deal a lot with prolapse issues, but also some of these incontinence problems as well, of course. And also urologists are trained in dealing with female incontinence issues. And everyone who has incontinence should really see a physician who has expertise in this area and not sit in silence. What can be the problems in terms of lifestyle? Well, they can become recluses because they don't want to be with other people because they know that they may leak and then they have a urine smell, or they may soil their clothing, or they're sitting on somebody's couch and their urine leaks out onto their couch. So they don't socialize. They become isolated and lonely. And this is a terrible thing. And in terms of fall risk, especially as women get older, urge incontinence is a really serious predecessor to falls. In fact, one of my aunts, my beloved Aunt Sophie, she died because of having urge incontinence. How could that happen? She was an elderly, wonderful woman, and she had this constant problem that she would have to go to the bathroom, and she didn't want to soil her clothing. So, and this was quite a while ago, and we didn't even have the specialty of urogynecologists and urologists were just learning about this problem. And so she would just wear diapers, the adult version, and she would wear pads. But one night she was in bed and she suddenly got the urge and she got up to run to the bathroom and she forgot she had left her slippers on the floor by the bed. She tripped over her slippers, rushing to the bathroom, not looking where she was going, and fell, broke her hip, and within just a very few months, she died of pneumonia. So her birth certificate said she died from a hip fracture and pneumonia. It didn't say she died from an overactive bladder that led to urge incontinence, and that's really why she rushed and fell and broke her hip and then got pneumonia. So really, the root cause of her dying was because she had urge incontinence, and she just didn't want to wet her clothes. So it's really a big deal. This is not just potential. This is what really happened in my family. So if you or someone you love has these problems with incontinence, please tell them to seek care because there is a lot that can be done.